This presentation will focus on troponin I and its relevance as a biomarker for cerebral vascular accidents. The objectives that I hope you as the audience to get out of this presentation, I want you to be able to define what a middle cerebral artery syndrome is. Though this syndrome is not the primary topic of this presentation, it is the medical diagnosis of the case study that I will be presenting, and thus is pertinent information for you to be familiar with. Second, I want you to be able to verbalize the prevalence of elevated troponin I or TNI in patients with post-acute CVAs. Recognize the risk factors in patients' medical chart and the potential causes of their elevated TNI. And fourth, I want you to be able to understand the clinical significance and increased risk when a patient presents with elevated TNI or dynamic TNI. So, are cerebral vascular accidents pertinent to our patient population? Of course they are. 130,000 deaths occur within the American public each year. That's a death every 4 minutes. 75% of these are new strokes. 25% of these are recurrent. The annual prevalence is close to 800,000. Male veterans showed to be at an 81% increased risk factor of having CVAs or strokes. 87% of the strokes are ischemic strokes. The case study today will focus on ischemic strokes. The U.S. costs are close to $34 billion each year. The VA alone, for each patient that presents with a CVA, the cost is 3.4 times increased that of the average patient. And finally, stroke is the leading cause of serious long-term disability within the American public. All right, so here's the definition of middle cerebral artery syndrome. It's, again, keep it pretty succinct here. It's a condition in which a complete occlusion of the middle cerebral artery leads to neurological and sensory and motor deficits. MCA is the largest of the cerebral arteries. It's the most commonly occluded. The left is a little bit more prevalent than the right, and the extent of the symptoms depend on the following: the size, the etiology, the location of the insult, the duration of how long it actually takes to come to fruition, and then the prior comorbidities of the patient and their health status. So for those who are visual learners, here's a couple of images. You have the mid-sagittal, the sagittal, and then the inferior aspects of the brain here. The rustic orange denotes the distribution of the middle cerebral artery. So I'm going to jump right into the case study here, and the reason why is because I really think it's going to provide you a foundation and context in which to relate the information from the literature that I will present back to the clinical setting. So this is a 63-year-old Caucasian female who has a medical history that's significant for hypertension, hyperlipidemia, diabetes, gout, and a UTI within the last 6 months. She first noticed symptoms on Saturday, January 23rd. It was about 15-minute bouts of headache and blurred vision after going for a walk. This occurred multiple times throughout the day. The following day, Sunday the 24th, she realized that she had some difficulty and trouble getting out certain thoughts. She never had symptoms like this before. She admits that she was concerned of a stroke. However, she thought that the symptoms would go away with rest and over time. However, unfortunately, they didn't, and they progressed over the coming days. She finally presented to the Veterans Affairs Emergency Department on the 26th, so that was January 26th. That's a Tuesday, 4 days after her initial symptoms, early in the morning at about 9:30. So she denies trauma or falls, recent illness, subsequent bouts of diplopia, weakness, gait deviations, chest pain or shortness of breath, no cerebral vascular disease, previous MI or arrhythmias. On physical exam, she was shown to have a significant blood pressure of 160/99 at rest. Her NIH stroke scale was 1. For those who are not familiar, it's a 0 to 42 scale. The higher on the scale, closer to 42, the more significant the neurological impairments and the more severe the stroke. Otherwise, she was fairly unremarkable. Over the 4 days within her admission, she did develop a slight pronator drift as well as expressive aphasia. The physical therapy evaluation I conducted in the presence of Tom Adair, the attending physical therapist, as well as another intern, Ryan, who was on the rehab unit at the time. So her subjective was a little bit tricky, as we had to phrase our questions so she could answer them in a yes/no manner, given the expressive aphasia. So here's just a snapshot. So our home environment is a third-story apartment, no elevators, and one handrail. So she had to be safe and efficient before discharge to be able to navigate these stairs. Her prior level of function, she was independent in all IADLs. She did have a sedentary lifestyle. The social history, she had a strong ward. For those who are not familiar, this is a small congregation within the Mormon faith. Her hobbies included gardening, planting. Her chief complaints, again, the difficulty word finding, as well as poor balance with higher level dynamic gait and balance activities. On physical exam, so her range of motion, strength, cranial nerves were relatively unremarkable and within normal limits. Her coordination of finger to nose had a mild deficit, so mild in fact that we couldn't really chalk it up to whether this was due to a recent neurological insult or whether it was her baseline. Her bed and transitional mobilities were unremarkable. She was able to navigate a full flight of stairs reciprocally, and then her FGA, her falls risk was a 22 out of 30. Wasn't necessarily due to her physical ability, but rather the communication deficit and understanding what we were trying to communicate to her and have her do with this physical performance measure. The education that we provided her with the CVA modifiable risk factors, prognosis, as well as how fortunate she was to be presenting at such a high level just so shortly after the stroke. Okay, I'm going to jump right into it here. So the focus of this presentation is on the relationship between CVAs and troponin I. For those who are not familiar with troponin I, it's a specific protein isoform that is found in cardiac myocytes and is used as a sensitive and specific biomarkers for MI. Now, I would assume that most of us are familiar with witnessing a surge in this protein following an MI, but perhaps not as familiar with it in the presence of an acute ischemic stroke, as I was not. All right, so here is what I've done. So I've taken the tropes that were trended throughout her medical chart, and I've put them over time. So the green line represents the most recent cutoff of 0.04 nanograms per milliliter, which represents the 99th percentile above the normal resting level of troponin I. You'll recognize the comment, it gradually rises and peaks as a normal troponin curve will. Note that the peak of the troponin I was at 46 hours post-admission and 18 hours in the evening of January 28th. Again, that 18 hours is in military time, so that's approximately 6 in the evening, for those who are not familiar. Also note that at 10 a.m. on the 26th, an hour after admission, the patient's CKMB value, which is another sensitive and specific biomarker for MIs, was in the therapeutic range of 1.2 nanograms per milliliter. Given the sensitivity and specificity of this protein, it makes that an MI upon initial admission unlikely. Let us compare this timeline to that of the American Heart Association. So the evolution of cardiac troponin assays and their diagnostic cutoffs is shown here. So you'll notice that it peaks between 24 and 32 hours. And then you'll also note that the dotted lines on the left-hand side of the screen just show the accepted cutoffs that have changed over the years, the most recent of which is that 0.04 nanograms per milliliter, as I mentioned previously in the year 2007. The significance of this is that it indicates the insult to the patient's myocardium occurred approximately 32 to 48 hours prior to the evening of January 28th, again at 6 p.m. A time frame that is not consistent with that of her initial neurological symptoms. What does this mean? It means that the approximate time that I've calculated is that the MI occurred early in the morning of January 27th, the day after admission, approximately at 6 in the morning or 6 a.m. Again, as she presented to the ED on the 26th at 9:25 a.m. and was admitted shortly thereafter, this means that the cardiac insult occurred here in the hospital rather than prior to admission. So this really got me thinking, what is the relationship here between ischemic insults and myocardial infarctions? Did she actually have a myocardial infarction? We know that those individuals who have MIs are at higher risk for stroke in the short term, but does that relationship work and vice versa? And so to really determine whether the first question of whether she actually had an MI, I looked at the diagnostic criteria that was put up by the American College of Cardiology in 2007. So they diagnose MIs with the following 4 factors. So cardiac troponin biomarkers, we know that she has that. We need EKG changes. We need imaging of new wall motion abnormalities on her echoes, and then her clinical signs and symptoms of ischemia. Of course, these signs and symptoms can be silent, particularly with those with diabetes, are known to have these more silent ischemic events within the myocardium. So the patient had cardiac troponin biomarkers. What about the other criteria? So we look at our medical chart here. We note that the EKG was relatively clean with a left axis deviation, which they chalked up to hypertrophy of the left ventricle. Her echo of the transtracheal as well as the TEE were relatively unremarkable. The significance here of the aortic calcification was that they were looking for the emboli that may have caused the ischemic stroke in the first place. Her CT angiogram, again, they were trying to really denote the neurological structures that were supplied and the specific vascular structure that was occluded. In the head, again, it was the same as what they had seen previously, so ischemic stroke as previously described. And then in the neck, she had mild cervical carotid and mild vertebral artery atherosclerosis. The auscultations, there was no murmurs, gallops, or rubs. And so how can we answer these questions? So she didn't necessarily fit the criteria except for the elevated troponins, right? So let's turn to the literature for some answers. So before I do, I just want to be clear on a term here. So acute coronary syndrome, this is an umbrella term for unstable angina, NSTEMI, and STEMI, and I'll be using it as ACS in the coming slides. So I did a literature review and have filtered out the findings into 3 articles. You'll note them here. You'll note that they are all relatively new within the last 5 years of the literature. And what I'll do now is I'm going to step through each of these articles and extract the pertinent information from each of them, and then we'll relate it back to the case. So this first one by Anders in 2013, this is a prospective study that was performed in Germany. It showed the clinical relevance and consequence of elevated TNI in acute ischemic strokes. And then what they did was they took 830 consecutive ischemic strokes, filtered out TIAs as well as hemorrhagic strokes, took the baseline troponins, then waited 3 hours, took the secondary assay of the troponins. If those troponins had elevated by 30%, they then denoted these individuals into the dynamic TNI, which is where our patient actually would fall. They then broke up the dynamic TNI into 3 different groups: those who had STEMIs, those that had NSTEMIs, and those that had no ACS. Again, our patient would fall into the no ACS dynamic group. So 30% or rise and fall, again, is the criteria that they use to differentiate between the dynamic TNI and the constant TNI, which did not rise with the second assay. And so I've graphed their findings here so it's a little bit more visually friendly and able to comprehend. So the prevalence of what they found is that those that presented with ischemic strokes, about 20% of those had elevated TNI, which is denoted by the graph in the upper right-hand corner of the slide, and you'll note by the blue, which shows the elevated TNI. The second graph here then breaks up that group that had the elevated TNIs into the 4 different categories. So you have the constant CNS, or the constant TNIs with no ACS, which is about 60%. The chunk that we're most familiar or most concerned with is that purple chunk there at 18%. So again, these are the individuals that have ischemic stroke, that have dynamic tropes, and have no ACS. This 18% is also consistent with a meta-analysis of 15 studies involving close to 3,000 patients that was found in Clinical Cardiology in 2009. And so they put the percentage at 18.1% of patients that present with ischemic stroke will have dynamic elevated tropes without ACS. So almost relatively identical to that of the findings of Anders. The graph here, again, it's what I really was trying to show was the fact that Anders had taken different factors within the medical charts of those patients that presented with the elevated tropes and no ACS, and we're trying to determine the potential factors that may have caused the elevated troponins. As you can see here, the AFib was quite common. ACS, obviously this doesn't apply to our patient. Our patient would fit actually into the unknown group, as they did not have CAD, they did not have AFib, and they did not fit the multi-reason cluster group that you see down there at the end at 4.4%. Okay, the second article, this is a study by Vanden Bosch in 2011. This was a prospective study done in the Netherlands. Consistently mentioned in the previous article, these authors reference the MI definition set forth by the European Society of Cardiology, relying on the elevation of troponin I over the 99th percentile of the URL, or the resting limit for the general population. So Anders' article defined AFib as being one of the most common causes outside of the presence of ACS. This article focuses on the AFib population. However, these individuals did not necessarily have ischemic stroke. These were simply looking at those that presented with atrial fibrillation and had elevated troponins. And they even showed to have elevated troponins below that subclinical cutoff of the 99th percentile. The significance of this article is the fact that they had broken down different mechanisms for explaining why the tropes were elevated in these patients that presented with AFib but didn't have ACS. The first is thrombotic ACS, which is obviously the most common. It doesn't apply to our patient, as she had no thrombi noted within the coronary arteries. The secondary is the supply and demand mismatch, leading to a type 2 MI. The fast ventricular response that leads to the demand ischemia within the ventricles. So the literature supports cardiomyocytes damaged in supraventricular tachycardia, arrhythmias. That's, again, arrhythmias over 100 beats per minute. Despite the SVT, 79% of AFibs have ventricular tachycardic rates. I want you to keep this one in mind, the supply and demand mismatch, as I think it will be most applicable later on in the presentation. The third is the coronary vascular resistance. Again, if you can't really dilate the coronary arteries and you can't get the blood supply and the oxygen there, there's going to be some ischemia leading to some death or necrosis of the myocardium, leading to the elevated troponins. The fourth factor there, so a fixed coronary vascular stenosis, occurred in 28% of the patients in this study. However, again, this doesn't is not applicable to our patient, as she did not have any thrombi or any atherosclerosis within the coronary arteries. And then finally, the reduction of cardiac output and the fluid retention with these patients that present with AFib. So you have the loss of the atrial kick, which accounts for 5 to 30% of the cardiac output. You have a shortened diastolic filling and higher afterload due to the fluid retention in these individuals, and this results in the stress on the ventricles and thus the necrosis. So again, keep these in mind. So if we look at the conclusions of what Vanden Bosch came up with, the one that I want you to be particularly familiar with is, again, that second mechanism, as well as the usefulness of the risk stratification that they determined that could be applied to healthy populations. So even those individuals that don't have ACS and are considered relatively healthy, if they have these elevated troponins within their blood, it can be used to stratify potential risk for long-term outcomes of these patients. The third article is Raza et al. In 2014. Now, this is a retrospective chart review study that was done at Temple in 2008 to 2010. The publication, again, is the most recent of the ones that are presented today. So these individuals are individuals who had ischemic stroke, and again, it's retrospective, right? So these doctors looked back in the medical chart over these 3 years or so at those individuals that presented with ischemic stroke and had elevated troponins, as well as those that had ischemic stroke and no elevated troponins, and they compared the two groups. And then they followed the medical charts of these individuals up until endpoints. These endpoints included MIs, major adverse cardiac events known as MACE, and any all-cause mortality. And again, the purpose is to compare those with elevated troponins to those with no elevated troponins. All the patients had the ischemic stroke. And so the conclusions that we can pull from this article is those that present with elevated troponins are at increased risk of all-cause mortality as well as MACE, or major adverse cardiac events. Additionally of note, though not applicable to our patient, those that present with elevated troponin, CVA, and CAD, TNI was the only independent factor that predicted the long-term cardiac outcomes. And that was in absence of the left ventricular dysfunction, which could not even predict MACE in the post-discharge of these patients. However, the elevated TNI could, just denoting the significance of this biomarker within these patients. All right, further conclusions here. So again, in the absence of ACS and acute stroke, consider the long-term significance of the elevated troponins. Elevated troponins in the presence of acute ischemic stroke lead to increased all-cause mortality, and TNI identifies these high-risk patient groups for MACE post-discharge. And the final thing that I want you to take from this article is this cascade here that shows the actual potential mechanism that causes the elevated troponins in cerebral vascular accidents and ischemic strokes. So you have the initial insult. This leads to an increase in catecholamines. The increase in catecholamines leads to an excessive calcium ion release. This induces a number of adverse events within the cardiomyocytes, leading to activation of calcium ion sensitive proteases, which may disrupt the membranes, the organelles, as well as the cytoskeleton of the myocardial leading to overall damage and necrosis of the myocytes, leading to the release of the troponin and the elevation within the biomarkers. They had a cutoff of greater than 5 millimoles of extracellular calcium ions, leading to the disruption of the microtubules and the death of the eventual death of the myocardial cells. And again, you can see the result of the end of the cascade is a reduction in cardiac function. So I know this is a lot of information coming from these articles, and so I've supplied you with the chart here. Again, for those who have access to the handout, again, this is also there for your review. Please feel free to pause the presentation at any point or at this point to review these and just familiarize yourself with the findings of these articles. As of right now, we're going to turn back to the case and relate this information back to our case study. So again, based on the neurological note on January 26th, the day that she presented, in the evening, she had worsening aphasia, nausea, and vomiting. Her EKG, though normal sinus rhythm, had occasional PVCs, no AFib, which we know is critical. However, her heart rate became tachycardic about 8 o'clock or so on that night after admission. This remained elevated for over 30 hours, peaking at 130 beats per minute the following day. And then she also had within that 48 hours, she had permissive hypertension. So those who are not familiar with this term, if there's a block in the river, then they will allow the river to flow a little bit faster for some time post insult, allowing the vasculature to kind of clear itself, and then they provided her with hydralazine with a goal of reducing her systolic blood pressure down to 130s. She was then transferred to the telemetry unit due to these changes in her hemodynamics. All right, so our hypotheses here for the elevated TNI. So she had no AFib, no ACS, no abnormal wall motions. She had evidence of She had no evidence of left ventricular or left atrial thrombi. At the time of suspected insult, she had a worsening aphasia. Potentially, this is an indication of an increased inflammatory process. We know what happens with the inflammatory process due to the Raza article, leading to the increase in cascade of the calcium ions and the eventual death of the myocardium, with the elevated proteases being active within the myocardial sites, as well as this uncontrolled hypertension of systolic in the 200s, as well as the tachycardia. And so this is where that second article comes in, where they propose the mechanisms, right? So maybe she was not in the supraventricular rate as was ruled out by the EKG. However, her ventricles were obviously working excessively hard for a period of time of 30 hours, which we can imagine would lead to this potential mismatch and potential death or injury to the myocardium. All right, so leading to discharge now. So she was admitted, and this is just kind of wrapping up the case for you. She was admitted to the rehab unit on February 1st. She had 3 hours of speech, OT, and PT per day. The interventions that the PT provided were FIM, balance, gait, ambulation, and education. The outcomes, she met the MCID for the FGA. Again, she was no longer a fall risk at 27 out of 30 at discharge. The PMNR and social work management provided her with home health PT at discharge on the 5th. All right, so the clinical implications here. So we need to recognize and identify elevated TNIs in those that present with ischemic stroke, and even according to that second article, maybe even in the healthy population, as we can use this as a risk stratification for these patients that are potentially asymptomatic at baseline. Second, consider the potential causes within the medical chart. And the significance of this is that it allows us to identify these patients who are at most risk, and not only that, but identify the reason why they're at most risk, so we can educate our patients as to the most prominent or the most relevant lifestyle changes that they can make to reduce their risk for these all-cause mortalities, the major adverse cardiac events after discharge. Additionally, I think that we can also educate the other healthcare providers, for usually when we see troponins that are not above a significant level or so, because you can get troponins up to even 75, where we know that this individual had 0.2, and there was still potential significant risk for this individual. But so usually, again, if the troponins are not significantly elevated, usually there's a sigh of relief from the healthcare providers, as though, okay, well, this is maybe a subclinical elevation in their troponins and doesn't actually impact the overall function of the myocardium, as shown by the echo and by the EKGs. However, we shouldn't be sighing with relief. We should be taking action and identifying these individuals as increased risk for, again, that all-cause mortality and major adverse cardiac events down the road. In conclusion, just some self-reflection here. So I felt as though things that I could have done differently would provide the individual with more specific education, though we did on that first visit, and I wasn't the one to follow up with this patient, unfortunately, as Ryan was on the rehab unit at the time and was the one to conduct her treatments going forward. at that initial eval that we could have provided more specific education to her at that time. Secondly, I think that she would have benefited from me having a better understanding of the associated risks that come with these elevated troponins had I really recognized what they truly mean. And then finally, I recognize that this is kind of a small piece of the puzzle, right? This is a single biomarker, but I think that it can be very telling and something that can be added to the toolbox of those who are already confident in treating ischemic strokes and helping those individuals regain their function. I think that it just provides us, again, another opportunity to educate our patients about the potential risks that they're at and how to specifically mitigate that particular risk. All right, if you have any questions, I'd be happy to take them. If you could post them below this video here at YouTube. And then finally, my works cited is shown here if you have any questions about the sources from where I pulled from. Thank you so much for listening.